Hello, thank you for joining today's NCCN patient webinar, Know What Your Doctors Know, Advanced Prostate Cancer. My name is Tanya Fisher, and I am the moderator for today's webinar. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 31 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. If you ordered a free book when you registered for this webinar, you should be receiving it shortly. The Know What Your Doctors Know webinars complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Joshua Lang. Dr. Lang is Vice Chair of Biomedical Research, Department of Medicine at the University of Wisconsin Carbone Cancer Center. Following Dr. Lang, we will hear from Jane Strauss. Jane is a GU oncology nurse, clinical team manager at University of Wisconsin Carbone Cancer Center. Our third presenter today is Meryl Nissenberg, patient advocate. Meryl is president of the National Alliance of State Prostate Cancer Coalitions and the California Prostate Cancer Coalition. Now I will turn it over to Dr. Lang.
Thank you for the kind introduction, Tanya, and welcome to everyone, and thank you for your attending. We're hoping that this is going to be something that will be helpful and beneficial for you in your understanding of advanced prostate cancer. So the outline for today's presentation, first I'll discuss the stages of advanced prostate cancer and the different diagnostic tools we use to try to understand the disease. We'll next talk about the different classes of treatments, followed by a discussion of genetic testing, and then how we use that information to optimally sequence these different treatment options that we have for patients with advanced prostate cancer. So let's start at the beginning. What is advanced prostate cancer? Well, if someone is diagnosed with prostate cancer and the scans that are performed do not show any signs that it has spread to other parts of the body, we consider this localized prostate cancer. And the goal of treatment, whether by surgery or radiation, is to cure patients of their disease. However, for some men, the PSA may start to rise after one of these treatments. In that situation, we call this recurrent prostate cancer. We often check that PSA test, but unfortunately, the PSA doesn't tell us where the cancer is in the body. So your doctor at that point in time would recommend that we perform scans. Now, there's three major types of scans that we use in prostate cancer, though there are some others out there that your doctor may recommend. The first are CT or CAT scans. These are performed to look at soft tissues like lymph nodes, lung, and liver, areas that prostate cancer can spread to. We also perform bone scans. This is a whole survey of the entire skeleton to try to see if cancer could have spread to bone. There are also what are known as PET scans, and it's a radio tracer, essentially something that goes to sites of cancer and can show if that's an active area of cancer. Now, there are different kinds of PET scans, and some don't work in prostate cancer. Now, the next question is, well, what if we have scans and we don't see any signs of cancer, but the PSA is still elevated? Why is that? Well, what that means is that this is something that was caught early, and the cancer may be microscopic or too small to see on CT or bone scans. So what is your doctor seeing when they order these scans? Well, as you see on the left, a CT scan is to look at soft tissue, such as lymph nodes. And that red circle highlights a conglomerate of lymph nodes that are enlarged from prostate cancer. In the middle is a bone scan. So this is looking at areas of inflammation in the bones that are often, though not always, caused by prostate cancer. And again, the red circles highlight areas where cancer is involving the bone. Now we have to be cautious though, because some of the times these scans can also pick up things like arthritis. So again, inflammation in the bones, but not related to cancer. And it's very important that your doctor understand which is which. And lastly, we have PET scans. And PET scans, as I mentioned, show how much of an injected radio tracer is taken up. Basically, again, is that an active cancer that's taking up that cancer or not, taking up that tracer or not? Now, there are a couple different kinds of PET scans. The classic one is what's called an FDG, or a radioactive glucose. FDG PET scans don't work very well for most men with prostate cancer. So a lot of work has been put into developing other kinds of PET scans that may be more sensitive and more specific. One is called Axumin, and a new one is called PSMA, or prostate specific membrane antigen, as a PET scan tracer. If a PET scan finds cancer, what do we do with that information? Well, if it's localized to only 1 or 2 spots, your doctor may recommend radiation to see if that might be able to kill those areas of cancer. It's not clear, though, if that type of radiation actually helps men live longer, though it has been shown in small clinical trials to decrease the PSA for the majority of patients. But also for the majority of those patients, the cancer did come back. If we see cancer in different parts of the body or multiple areas, that's where the role of radiation probably isn't very useful and may cause other side effects. Now, what if the PET scan doesn't find any cancer either? In that situation, this could still be a microscopic cancer, and your doctor may recommend radiation to the pelvis along the ideas that if that's where the cancer started, that maybe there's some microscopic cells still there and radiation could help eradicate them. Your doctor may also recommend hormone therapy. It's often, but not always, given with pelvic radiation and is an important question and discussion to have with your doctor. So what if radiation is not an option? So if the scans that are performed see that cancer has spread to different parts of the body, whether that's in multiple spots in bones, lymph nodes, or other tissues, this would be called metastatic prostate cancer. There's another term that you may see or hear called castration-sensitive prostate cancer. And what that means is that this is a cancer that's still sensitive to the hormone therapies. In metastatic castration-sensitive prostate cancer, we do not recommend radiation therapy. Importantly, the goal of treating this type or this stage of cancer is to improve quantity and quality of life. Unfortunately, it's not a cancer that we can cure, but our hope is that with all of the different treatments we have, that our patients will have many, many years of good quality life ahead. But it will require the use of these anti-cancer treatments. So let's talk about those treatments themselves. So if we go back to 2010 and we look on this graph, what you're seeing here on the axis is tumor burden and tumor activity, basically saying how much cancer is present and is it something that's growing. And on the bottom axis is time. And as you can see, when we follow that red line, that we start with local therapies, so that's radiation or surgery. But as the red line goes up, meaning the cancers come back, we often start with hormone therapies and sometimes combination hormone therapies. And that can knock the cancer down, and as you see, that red line drop. But unfortunately, for nearly all men, the cancer ultimately becomes resistant to hormone therapies, what we call castrate-resistant prostate cancer. Now, in 2010, unfortunately, the only treatments that we had were chemotherapy-based options, things like docetaxel or platinum chemotherapies. Now, if we fast forward to 2016, you can see we have many new treatments. And again, it was because of the incredible donations of time from our patients and from their families for those men to enroll on these clinical trials. And what we now have are new classes of hormone therapies, drugs like enzalutamide or abiraterone that also block that hormone signaling pathway. We have other chemotherapies with cabazitaxel being approved that's been shown to improve survival. We also have the FDA approval of immune therapies with Sipuleucel-T or Provenge. And then also a new class of targeted radiation therapy called radium-223 that only goes to sites of bone. If we go ahead into 2018, we have even more androgen receptor signaling inhibitors, or ARSIs, or ARIs, or NHTs. You'll hear a lot of acronyms here, so just be sure to ask your doctor exactly which drug they're talking about. But in this case, we have apalutamide now approved. And then we also found that if we use it even earlier in the disease process, not waiting until the cancer becomes resistant to hormones, that also can improve survival for men with prostate cancer. And then we have even more therapies, and this brings us up to 2020, where we have the FDA approval of new targeted therapies, such as rucaparib and olaparib for patients that have specific genetic mutations in their cancer. We also have the FDA approval of darolutamide, another hormonal-based therapy. Now, this looks like a really complicated slide. So what do we think about in terms of breaking this down? So we can simplify this slide to those classes of therapies that I mentioned. So hormonal-based therapies, those ARIs or ARSIs, such as enzalutamide or abiraterone, chemotherapies, and targeted therapies. Now, one of the important aspects that we've learned over the years using these different treatments is that if the cancer becomes resistant to one drug in a class, such as becomes resistant to enzalutamide, going right into using another drug from that same class is unlikely to be effective. And we'll talk a little bit more about that later of how we understand each person's cancer and tailor our treatment recommendations to each individual. Now, one important point that I wanted to start with is that for men who present with metastatic castration-sensitive prostate cancer, I mentioned how we used to do hormones first, and then if the cancer became resistant, we went to chemotherapy. But some very important clinical trials were performed that found that if we gave chemotherapy early on, that significantly improved survival, on average about a year, for men with metastatic castration-sensitive prostate cancer. Now, chemotherapy, no one wants chemotherapy, but at the same time, we're much better at managing the side effects than we ever have been. So things like nausea and vomiting are actually quite rare with the right supportive medications. Now, chemotherapy, this kind is given on an IV infusion once every 3 weeks. We give 6 cycles and then we stop. The most worrisome or serious side effect is that the immune system can be weakened. Be sure to ask your doctor about booster shots that can help support your immune system during this time. At the same time, there were other clinical trials going on with other hormone-based therapies. I mentioned abiraterone, enzalutamide, and apalutamide. These are all drugs that are pills taken once a day, and they help to target hormones even more effectively than the hormone therapies themselves. Now, the side effects include fatigue, muscle weakness, and osteoporosis, which also highlights really the importance of being active during any of these therapies for cancer. Cardiovascular exercise and weight training absolutely make a difference to help manage some of these side effects. How do we pick which one? Unfortunately, we don't have any head-to-head clinical trials asking if one is better than the other. What we do know is that they're about equally effective in these different trials. So there are other factors that can play a role in helping in your doctor deciding which treatment to recommend. Unfortunately, for many of my patients, cost is a big part of that decision, whether that's Medicare or private insurance. There are some trade-offs too. A short course of 18 weeks of chemotherapy versus years of intense hormone therapy. Some people like to rip the Band-Aid off. Others don't, and that's okay too. Again, there's no head-to-head comparison, so weigh these different factors and discuss this with your doctor to find which is the best option for you. Now, other questions that may come up of, is there anything else that we should add on top of these other therapies? One active research question is, well, what if a man presented with metastatic prostate cancer? They never had surgery or radiation. Is there any role to treat the place that it started? Now, usually we only do a radiation treatment to the prostate if there's other symptoms of pain or difficulty with urination. The concern with surgery is that that could delay the initiation of some of those therapies that I just mentioned. There are research studies going on to try to ask if more aggressive treatment to the primary tumor is indicated, and hopefully we'll have results within the next couple of years. Now, I want to introduce you to one of my patients. This was a young gentleman, only 53, and at the time he had had difficulty with urination. He went to see his primary care doctor and he was treated with antibiotics for what was thought might be an infection in the prostate. Ultimately, his PSA was checked and it was found to be elevated at 18 nanograms per ml, with normal being between 0 to 4. He was referred to a urologist and a biopsy was performed that found a high-risk aggressive prostate cancer. And my patients asked me, why did this happen in the first place? And that leads us to the importance of genetic testing in prostate cancer. So when I asked my patient, tell me a little bit about your family history. He said, his mother was diagnosed with breast cancer in her early 50s. She had an uncle diagnosed with prostate cancer in their early 50s. And my patient was married and he has 2 daughters at the ages of 12 and 14. So at that time, we talk about the importance of genetic testing in prostate cancer. Now, there's 2 major types of genetic testing that we recommend for men in this situation. The first is genetic testing on the cancer, meaning looking at different genes to try to figure out why did it develop in the first place? Are there specific mutations? And could there be drugs that might be effective to target those mutations? drugs such as olaparib or rucaparib. We also recommend testing the normal cells, whether that's a blood sample or a saliva sample. What we're doing is looking at the normal cells to find anything that could potentially be inherited, that could come from family member to family member. And the NCCN recommendations are that all patients at high risk or those with metastatic prostate cancer should consider genetic testing and genetic counseling. So what are some of those genes that we're really worried about in prostate cancer? The two most important ones are the BRCA2 and the BRCA1 genes, or the BRCA genes. You've probably heard about these because of their association with breast cancer risk. It took many more years for the field of prostate cancer research to catch up, but we found that these genes can be mutated in up to 20% of men with prostate cancer. They can also be inherited. And some of our research studies suggest that if a man with prostate cancer has one of these mutations, they could be found in up to over 50% of their first-degree relatives. So that includes parents, siblings, and children. Again, really highlighting how important it is to do this testing for our patients, but also for their families. Now let's talk a little bit about how do we sequence treatments. And again, the importance of getting data to help us inform, because every person is different, every cancer is different. So to start, I want to talk about men who have symptoms from their cancer. Pain is one of the more common symptoms if men have cancer in the bones, but not always. We know that it's important to treat those symptoms. So whether that's medications such as opiate pain medications, radiation treatments to specific areas causing pain, that can be very effective. I also mentioned the role of radium-223. That's essentially an IV form of radiation that only goes to areas of bone. It's important to note, though, that we rarely see changes in the PSA, though some men can have improvements in their symptoms, and this treatment was also shown to help men live longer. Now, also supportive care is really critical. The more we can do to help our patients feel better, the more they're able to be up and active and enjoy their life. And as I mentioned before, being physically active and exercising is important for all men, no matter where they're at in their journey with prostate cancer. I mentioned the importance of genetic testing. And if we see one of those BRCA1, BRCA2, or other genes in that family, we know that the drugs like olaparib and rucaparib can improve survival for those men. There's other immunotherapy, something called pembrolizumab, that's also FDA approved for men with this stage of prostate cancer, if there's a specific genetic mutation called microsatellite instability, or MSI. Now, if someone's having symptoms from their cancer, we often recommend chemotherapy. The reason being is that chemotherapy often works faster, and the hope is that we're going to get more effective symptom control to help our patients feel better. And if there's some concerns that this is a very aggressive prostate cancer, sometimes we recommend combination chemotherapy. Sort of that idea that if the cancer is causing more problems, we need to hit it harder. And that's a trade-off for the side effects that can happen when we combine chemotherapies. And lastly, I'll always recommend clinical trials. These are the most cutting-edge treatments. And I still remember back when I was a fellow and we had the first clinical trials with abiraterone and enzalutamide, and just what an incredible benefit that was for our patients before those treatments were approved by the FDA. And we don't need to wait until the end or late stage prostate cancer to consider a clinical trial. We have treatment options that are trying to improve the efficacy of all of our therapies for men with nearly every stage of prostate cancer. Now, one other important question is, can prostate cancer change? And most prostate cancers, 95+% of them, start off as what we call an adenocarcinoma. Essentially, it's a cancer that makes PSA. Some more recent studies, because of the generous donation of patients who said, you know what, I'm okay, do a biopsy and do genetic testing and any other kind of research test to try to understand my cancer. We were able to understand that in some men that cancer can change. About 15 to 20% of men can develop what we call a neuroendocrine prostate cancer. Now that's a cancer that essentially is not very sensitive to hormone therapies. And what I'm showing you here on this graph on the right is a graph where each line is a different group of patients. In yellow, these are men that had no signs of those neuroendocrine prostate cancers, while in blue is men who did have those signatures. And each kind of step down the ladder that you're seeing, that's when a different patient stopped that trial because their cancer progressed. And what you can see is that for men, if they have those neuroendocrine prostate cancers, those can be more aggressive and we need to change our treatments. Sometimes combination chemotherapies are the best ways to treat those neuroendocrine prostate cancers. So this is where we want to be asking a number of questions. The first question is, which kind of cancer does our patient have? Is this that original prostate cancer, or could it have changed? How information about what kind of cancer our patient has, how would that influence the treatments that we would recommend? Again, the importance of doing a biopsy. And also, which biomarker test should we order? There's a number of different ones that are out there, and which one is going to be most important for my patient at the time I'm seeing them in clinic? And then lastly, is chemotherapy the right option, or can we look at some of those other classes of treatments? So for my patient who's having symptoms from his cancer, we look at some of those FDA-approved options. So Sipuleucel-T, Provenge, again, an FDA-approved immunotherapy shown to improve survival. Unfortunately, we almost never saw cancer shrink or PSAs drop for men on that clinical trial. So if someone's having symptoms from their cancer, it's unlikely that Sipuleucel-T will improve those symptoms. Radium-223 is an option, though again, we don't expect to see PSA responses. They can happen, but again, it's very important to monitor the disease during that time. Enzalutamide we may not recommend, especially if my patient has already had a drug like abiraterone. Again, that might be the time when we want to be thinking about chemotherapy again. But as I'll show you in a moment, there are still some patients that benefit. We also mentioned cabazitaxel and platinum doublet chemotherapy as other options, again, when cancer is causing symptoms. And as I mentioned before, clinical trials, always think about them, and the sooner the better. Now, I mentioned why we may not want to consider enzalutamide and we might recommend chemotherapy. So this is another one of those clinical trials. And again, incredible thanks to the patients and their families who participate in these clinical trials so we could learn this information. What you're seeing here, again, each step on this ladder on each line is a patient who is on that treatment. And then when the ladder drops, they stop that therapy. So in the blue line, you're seeing are patients who receive that cabazitaxel chemotherapy. And the red line is patients who received abiraterone or enzalutamide, meaning if they had abiraterone before, they switched to enzalutamide. If they had enzalutamide before, they switched to Abi. And what we saw in this clinical trial was that more men responded or had a benefit from chemotherapy in that clinical situation. Now you can still see, though, there are some men, as we follow that red line down, that did benefit from enzalutamide or abiraterone, again, when we're doing that class switch. So it may still be an option, but it's really important to discuss with your doctor which is the best treatment for me at this time. Now, for me, this is where I want data. Again, because each person and each cancer is different. So this is where the importance of doing a biopsy is recommended. Again, looking at different genetic tests, but also looking for that neuroendocrine prostate cancer. And that may help us identify some of those other treatments that I mentioned. Olaparib, rucaparib for BRCA mutant prostate cancers, pembrolizumab maybe, or chemotherapies. Now, when your doctor may recommend a biopsy, they'll discuss, is it better to go for a lymph node or a soft tissue? The reason they may recommend that is because it's easier to get DNA out of those soft tissue areas to do genetic testing on. But we've had much more success recently with bone biopsies, meaning that it's much safer to perform and much more effective when you go to a high volume center, usually an academic institution, where the success rate should be 80 to 90%, as it is here at the University of Wisconsin. And again, because bone biopsies, well, for many of my patients, that's the area that's causing symptoms or pain for them. You know, I'd like to know what's happening in those areas of cancer if it's safe and feasible to do. Now, I'm going to stop and hand the mic over to my research and clinical nurse, Jane Strauss, to discuss how we care for men with advanced prostate cancer.
Thank you, Josh. Yep, so I'm going to be talking today about advanced prostate cancer implications from a research nurse's perspective. The topics I'll be discussing are managing treatment side effects, providing supportive care resources, clinical trial participation, and I will summarize at the end. In discussing managing potential side effects for men with metastatic hormone refractory prostate cancer, one of the most common therapies is hormone therapy. And so research nurses sometimes have to manage side effects such as hot flashes, decreased libido, fatigue, depression, and weight gain. For weight gain, depression, and fatigue, one of the things that we recommend is daily exercise, whether that's daily walking, even if it's 15 to 30 minutes a day. That seems to help with those three issues. And then when it's hot flashes, if the hot flashes are severe enough, we may recommend some medication to treat those hot flashes. It just depends on the severity and how much that's bothering the patient. Now with ARSI therapies, such as enzalutamide, one of the most common side effects patients report is fatigue and cognitive impairment, whether that's memory or speech. So many times under a doctor's supervision, they will recommend just giving the patient a drug holiday, whether it's a week or two, and then restarting at the same dose or at a reduced dose. That seems to help. And again, with fatigue, we recommend daily exercise as one of the things to combat fatigue. With chemotherapy, the two most common chemotherapies we use are cabazitaxel and docetaxel. One of the risks of chemotherapy is infection. So we always teach our patients, if you develop a fever above 100.8, or you have trouble urinating or burning urination or a new cough, please be sure and call us, because then we'll definitely direct them to seek medical care immediately. And then again, fatigue is a common side effect of chemotherapy, peripheral neuropathy. So we definitely have to assess for that each time they come in. And then hair loss. But we always mention that the hair loss is temporary. And it definitely will grow back months after the chemotherapy is done. And then looking at immunotherapy under research, one of the most common drugs is anti-PD-1 drugs, drugs like pembrolizumab. We always teach our patients, please be sure and call us if you develop any side effects such as diarrhea, thyroid dysfunction, rash, cough, or shortness of breath. We want to make sure that they don't have something that's called pneumonitis or colitis. And sometimes we have to give them steroids in order to cool down the immune system. So we definitely teach our patients when to call if they develop any of these symptoms. Supportive care for metastatic castrate-resistant prostate cancer. Many times we will refer them to palliative care for a consult, because psychology research has shown patients under duress prioritize immediate needs over medium or long-term needs. So we sometimes will refer to them sooner rather than later, because it's much more hard to discuss these, have these discussions when patients have symptoms from their disease. Again, we refer patients to radiation for palliative means for symptomatic pain. That definitely is a great option. And then also we do a lot of pain management with steroids, whether it's dexamethasone or prednisone for bone pain. And then sometimes we'll use short-acting or long-acting opiates. And please keep in mind that there is very to little no risk of opiate addiction when treating patients with cancer, treating pain for patients, with cancer. Very low addiction rate. Supportive care. Research nurses use a lot of patient resources. One of the most common that we refer patients to is social work, because patients have a lot of questions about long-term or short-term disability. They have questions about insurance concerns or treatment costs. So we definitely use social work the most. We also refer patients to health psychology, because many of our patients are definitely coping with a serious illness, and some really need to reach out to a health psychologist. Many of our patients reach out to support groups. There's internet chat groups. PCF.org has a list of support groups that a lot of patients refer to. There's also us2.org or Cancer Support Community or NASPCC.org. Those are very, very helpful sites. We also refer patients to, there's medical resources such as urology. If a patient's having trouble with urination or erectile dysfunction, we'll refer them to urology. We utilize pharmacy quite a bit because a lot of our research drugs have drug-drug interactions, so we need their input quite a bit. Again, we refer patients to radiation, so sometimes we'll be the ones calling to schedule that appointment. And then there's financial assistance for patients with clinical trial participation. It's actually a national company in the U.S. that helps provide travel reimbursement for those patients that qualify based on their income. And switching gears, looking at clinical trials. As a research nurse, one of the things that we have to definitely provide the patient is an informed consent form. And sometimes that can be 30 to 40 patients long. So we try and break it down as to what are the most common side effects versus what are the less common side effects so that our patients are fully informed. This is definitely a shared decision-making process between the patient and their family and their primary care doctor. Sometimes the patients will take their consent form to their primary care doctor or their referring oncologist to get their input. We always tell patients too on a trial that you have to go through a process of eligibility, and that is built into the trial for safety reasons. So once we explain that to the patient, they understand that. You know, we always go through the risk of side effects. You know, there's a fear of the unknown, so we always point out again these are the most common side effects. You know, you could have these, and definitely you need to contact us if you have any of those. One of the processes that the research nurses go through with presenting a trial to a patient is we have to discuss costs. That is definitely a concern for patients going on study. So we explain standard care costs versus what the research trial will pay for. And then again, we always have to tell them that if you do a trial, there's going to be an increased number and length of stay visits, whether it's blood draws, MD visits, and the treatments. Again, those are all for safety reasons. And we also have to discuss with the patients, please let us know what vitamins and give us a complete list of medications that you are taking so that we can consult our pharmacy to make sure that there's no drug or herbal supplement interactions. So I talked to one of our patients that was on a trial, and I asked him, well, what are the advantages and disadvantages of participation? And one of the advantages, he said, is it gives me a feeling of helping in a small way in our fight against cancer, and not just treading water, waiting for the inevitable to happen. He also said it pushes me to work out and exercise as long as possible, gives me the confidence to talk with people, and when they find out about my journey, perhaps the journey they are about to begin, and have personal questions. The disadvantages that he mentioned are, he can't turn around and just take an over-the-counter medication when he feels like it. He has to ask the research nurses if this is okay to take. Disadvantages such as fatigue being a side effect, definitely that can be an issue. And then traveling to the appointments, this can be somewhat tiresome. There are going to be extra visits involved, and we always make sure we tell our patients that there's going to be extra visits involved, and the visits may be longer. So in summary, research nurses play a very important role in providing quality care. We do a lot of phone triage with managing side effects. We are their patient advocates. That especially became true during COVID, because we might have been the only other person besides the physician in the patient room, along with the patient. We are their navigators. We do all the scheduling. We navigate them through the whole entire, clinical trial participation system. We do a lot of patient family teaching with oral medications and just when to call if there's side effects. And then again, we're their support staff. So in summary, that is our role.
Good afternoon and good morning, depending where you are. And welcome to the NCCN's excellent webinar today. We're really excited to be here, and I want to thank again the NCCN for the opportunity to present. So you've heard about informed discussions and you've heard about shared decision making this morning. this afternoon. It's obvious that the better informed the patient is, the better he'll be able to help with informed discussions and to engage in better shared decision making. We understand that it's also a need, or there is a need, to educate and to make better informed the physicians, because whether it's a general urologist or a general medical oncologist, they're treating a lot of different conditions, a lot of different issues come up, and they're not always schooled on every nuance and every new development in prostate cancer. So we want to aim to increase the information and the education of both patients and physicians. And this will lead to better shared decision making, in our opinion. The benefits of shared decision making, if it truly is the patient is more satisfied, better satisfied with the decisions that they have made. So they're more likely to follow the directives of the physician, more likely to take their treatments, and more likely to be compliant. They have less decision regret, which is extremely important, because many patients feel like maybe they chose the wrong course of action, or maybe they listened to the physician's recommendation that didn't really play a significant part in making that decision. So they end up with better outcomes, a greater feeling of empowerment, and improved emotional well-being, because quality of life, which we haven't touched on that much this morning, is a very important factor in being a prostate cancer patient and the family of the prostate cancer patient as well. Examples of how to educate patients and physicians. So we at the National Alliance of State Prostate Cancer Coalitions have created a series of what we call laminates, and they're two-sided, laminated 8.5 by 11 durable resources, and they are meant for patients and physicians, and they're a great tool for awareness as well as education in prostate cancer. The one that's on the screen now is informed decision making for men 40 and over, and this came about in 2013 when the U.S. Preventive Services Task Force decided that men should not be screened for prostate cancer. And the heading of their recommendation and their guidelines was a D, meaning do not screen. And most people read the topic and the title and decided that the physicians didn't even need to bring up the topic of prostate cancer anymore, much less have an informed discussion or offer testing. And we went back after we did a pilot project, because these are two-sided laminates. So as I say, one side is 10 questions to ask your doctor about whatever the subject is, in this case, informed decision-making and you and prostate cancer. But the beauty of these is that the flip side is for the physicians. So on the physician side for each of the laminates, it will say, please review the 10 patient questions and answers on the reverse side. We then answer the same questions for the physician, but using the scientific references, citing the studies that they're based on, et cetera. So we were told by a few physicians when we distributed these at first that they weren't allowed to have an informed discussion, which made no sense to us. So we went back and with a fine-tooth comb looked at those guidelines. And sure enough, the middle paragraph of those guidelines said that if a patient was interested in and wanted to have an informed discussion about prostate cancer testing and screening, that the physician had to, so it was mandatory language, be prepared to have that discussion, and then the decision to test would be based on the patient's preferences and decision making. Nobody even knew that. They only looked at the title, the D recommendation. So once we realized that, we had added a little yellow box on the top of the physician's side, referring to the fact that they were indeed allowed to have an informed discussion and what the ramifications would be. So this is a great tool. We distribute these by the thousands. We distribute them to primary care doctors and to urologists, to men as yet undiagnosed, to men in early stage disease, even men in support groups, because they can go out and help other men ask the right questions. So these laminates, as I say, they're durable, they're easy to store. The patient is meant to take it along with him to the physician's office to help guide the discussion. And it's a kind of empowerment, so the patient is not going to be nervous and not know what to ask and not know what questions to consider. And physicians also keep a series of these laminates handy for reference for their patient discussions. And another benefit is that the patient can go not only read their own side for the patient, but read the flip side, so know what the physician's going to be talking about and maybe do some early research on the studies that are mentioned, and the physicians can see what are the patients coming in with, what knowledge are they armed with at the time of the first meeting. So that's really a great opportunity. And we have gone on and we always keep the 10 questions and answers format on the patient side. The more scientific answers and references, same questions, physician side, and we do double distribution. So we're trying to get the word out there as best we can. The next in the series that we did is the role of PSA through the full spectrum, well, the role of PSA throughout the prostate cancer journey. Underneath that, we say PSA's role through the full spectrum of prostate cancer, which cannot be overestimated. Most people think of PSA strictly as the initial screening. There's a lot more to PSA and a lot more to the uses of PSA. So, for example, what is the PSA test? What causes an elevated PSA? What is PSA density, velocity, doubling time? Can prostate cancer be diagnosed only on the basis of high PSA? And can you have a low PSA and still have prostate cancer? We know the answer to that is yes. How important is PSA during active surveillance? What happens to your PSA after you have localized prostate cancer treatment? What is PSA persistence and recurrence? And Dr. Lang spoke about recurrence. And how is monitoring used to see if the disease comes back? What is castrate-resistant prostate cancer, and is PSA monitoring important in that? And what to ask when your PSA continues to rise. And again, these are the 10 questions to ask your physician, and the reverse side for the physician with the studies. So that was our second laminate, and these are all on our website and available for downloading as well. The next one is non-metastatic castrate-resistant prostate cancer. And Dr. Lang spoke this morning about castrate-resistant prostate cancer, but many times it's diagnosed as castrate-resistant. You're no longer responding to hormonal therapy, but there is no evidence on basic imaging of any metastases. I won't get into oligometastatic disease at this point, but so this is called mCRPC, and there are treatments that can either delay or sometimes even prevent metastasis. And the 10 questions to ask your doctor about mCRPC: what is it, first of all? What does it mean non-metastatic? How is PSA monitoring helpful? What types of imaging are generally used? This is conventional imaging. And does functional imaging play a part? So we're looking at PSMA PET and other types of scans. It's very important because some insurance companies don't want to pay for treatment that you would have if you're considered non-metastatic, and yet you may have 1 or 2 up to 5 sometimes small lesions that can be treated on their own, but the treatments for a non-metastatic may still be very valuable. So this is really important. Should it be treated systemically? What is the treatment? Are there therapies to protect bone health and cardiovascular health? Patients in this age group usually have other comorbidities, other possibly heart conditions, blood pressure issues. So it's very important to know. I think we talked about earlier the drug-drug interactions, potential of that. What are the quality of life issues that should be considered in non-metastatic CRPC? And how will I know if my prostate cancer becomes metastatic? Again, 10 questions to ask your doctor, flip side for the physician. We always have that yellow box up there as well. And lastly, the fourth in the series that we've done so far is metastatic castrate-sensitive prostate cancer. And as Dr. Lang spoke about, these patients have metastases, they have widespread disease, but they are still responsive to hormone therapy. It's a completely different category. It's called mCSPC. And questions here include, what is it? Does it include metastatic disease at your first presentation? In other words, when you're first diagnosed with prostate cancer, is it already metastatic? What is high volume and low volume metastatic CSPC? This is very important because the studies that approved some of the ARIs that Dr. Lang spoke about actually had different results, whether or not the patient had a lot of disease, very high volume, or very low volume. Again, should it be treated systemically? What are the most effective systemic treatments for mCSPC? How is it personalized on the basis of what clinical group you're in? This is, again, very, very important. And Dr. Lang, you did a great job breaking it down. That's a huge topic, and I think you laid it out beautifully. What is the role of metastasis-directed or focal therapy? to the setting. You increase the benefits. You treat focally if you have some of these smaller lesions. The role of local therapy to the prostate if you have metastatic CSPC, at this point only through clinical trials that both Dr. Lang and James Strauss handled this morning. The quality of life issues, and is PSA monitoring used in mCSPC? And again, patient and physician. These are available. We also send them out in groups of 100 physicians and patients. They're just a great tool, and no one else is doing them. So, and then for more information, I would ask that you visit our website, naspcc.org. We have a number of resources on there. We've got the Laminates, as I've just mentioned. On the left side of the screen, you'll see the informed decision making, which was the first one. And then you'll see another tab that says new laminated resources, the other three I just mentioned. But we have monthly webinars, and we actually archive both the recordings and the slides. Those are a continuing resource. We actually publish now Prostatepedia, the quarterly magazine, and the Every Friday Weekly Digest, which summarizes all the latest abstracts and articles in prostate cancer for that week. And we do a lot of other things, including an annual meeting, and we are here to answer any questions. So I hope that this has been helpful, and I think we're ready for questions.
Okay, so our first question, a patient has had a radical prostatectomy and has small but slowly increasing PSA. At what value of PSA would a metastatic tumor become visible in a PET Axumin scan? And are there other PET scans available?
This is a great question, and one that's, I think, really critical. That if the PSA does start to rise after surgery, it's very important to be referred to see a radiation oncologist. Now, that radiation oncologist will talk about what's that change in the PSA, the doubling time, the velocity, etc., and say, is this a time where radiation to the pelvis might be helpful, just in case those microscopic cells making that PSA are still in that area. Now that's where we ask, should we do an Axumin PET scan? So that's an FDA-approved scan that's available universally. Axumin is generally sensitive when we get down to somewhere around a PSA of around 0.2 or 0.5. So it's good, but it's not perfect. Now, there's other PET scans, a lot of research, very active area of research, and PSMA, or prostate-specific membrane antigen, is one that's also getting a lot of press these days, and one that we're very excited about. It does seem to be more sensitive than the Axumin PET scan. However, it is not effective when we talk about PSAs in that 0.02, 0.03, 0.04 range. That's still too low for PSMA PET. But that's a discussion that you want to have with your radiation doctor. Is what's the right time and which scan should we have performed?
Okay, thank you. We did receive a couple of questions via email, so I'm going to read one of those now. Are there any long-term implications or effects for men who have a low PSA under 1.6 at diagnosis and treatment?
So one of the things we very much worry about when PSAs are very low is that this is a cancer that is maybe not as sensitive to hormone therapies, meaning it doesn't use hormones to grow the way the majority of prostate cancers do. This is a time where it's very important to do early genetic testing to find out, is there some other genetic mutation that caused this cancer to develop, especially if it's one that may not be as sensitive to hormones. Now that doesn't mean, that's not an absolute. Men, even in this situation, should still be considered for hormone therapies if the cancer comes back after surgery. Hormone therapies, abiraterone, enzalutamide, those are all options that should be considered. But we do want to be more careful using scans to monitor the disease and don't rely on PSA as much.
Okay, great. Thank you. Why are oncologists, at least two I've had, reluctant to order DNA testing? And then there's a couple of follow-up. Why is there a reluctance to order Provenge when indicated per guidelines? And how would I overcome these objections?
Right. I'm going to start with the genetic testing question first, and I think that's also been repeated, Mr. Foreman, in the Q&A, as well as a couple of others. Obviously, I'm not in that camp. I believe genetic testing is critical for men with prostate cancer, especially with the approvals of olaparib and rucaparib, which we can only give to men if we've had genetic testing on the tumor. Now, there's some different types of genetic tests. You may hear genomic and genetic used. For the most part, those terms are interchangeable. Really what you want to be asking is a genetic test being performed on the tumor, or is it being performed on the normal cells in the body? And again, men with metastatic prostate cancer should have both performed. Of those different genomic tests, again, there's different results and your doctor can work to interpret it. I will say though, some of them are very complex. Some of these genetic tests look at over 500 different genes. And I like to think I'm pretty up to date, but I'm not an expert on 500 different genes. So that's where it's so important to collaborate. At the University of Wisconsin, we have a free statewide molecular tumor board. We actually review genetic tests. There's a group of 20 of us from across the state and people with different experiences and different specialties, especially if we find a rare or uncommon genetic mutation. MSI is a really good example of that. One that we only see in about 3% of men with prostate cancer, but if it's there, that means pembrolizumab might be a good treatment option for that patient. So again, it's the importance of looking at those genetic tests and interpreting them with your doctor, and then reaching out for help if it's one of those more complex or uncommon genetic test signatures.
Okay, thank you. When would the combination of carboplatin and cabazitaxel, be used is especially effective for BRCA2 patients?
Yep, cabazitaxel. Carboplatin and cabazitaxel. I practice that a lot to get it down. So when we think about BRCA1 or BRCA2, essentially what those genes are important for is cancer healing its DNA. If the DNA is damaged, that cell's going to die. So those genes are important for healing that DNA. Now, drugs like olaparib and rucaparib block that or prevent that from happening. Some chemotherapies, the platinum chemotherapies, specifically damage DNA. So that's where men who fall in that category, if you have one of those genetic mutations, those olaparib and rucaparib are two important options that should be considered. If those drugs stop working, that's where we are learning more about the whys. Why did those drugs stop working? And usually it's because of new genetic mutations in the cancer. We can only figure that out with a biopsy, and there's a lot of research studies going on. And I just want to thank the patients who are involved in those research studies, helping us to learn to help all men fighting this disease. But that's also when your doctor may think about those platinum chemotherapies. Again, ones that more specifically damage DNA.
So where does Leuprolide acetate fit into this mix of treatments?
That's a great question for Mr. Green. I think a couple of other folks asked those questions as well. So Leuprolide, goserelin, relugalex, those are all classes of agents that fall in this category of androgen deprivation therapies. Essentially, all of those therapies bring testosterone down. The goal is less than 50, and they're effective to do that in over 95% of men. In fact, they're so effective, we don't check testosterone levels for most men. Is there one that's better than the other? Probably not. They've never been compared head to head, but as long as the testosterone is low, I'm not really concerned which one my patient received, as long as the testosterone is low. Now, what if the cancer becomes resistant to that hormone therapy alone? And that's when we use that term castration-resistant prostate cancer. We still recommend continuing that hormone therapy. The reason why is that if we stop it, we expect the testosterone is going to start to rise again. And even in these resistant cancers, if there's more testosterone around, they're probably going to use that and grow faster. So another reason where those hormone therapies, again, Lupron, Leuprolide, Zoladex, relugalex, those are ones that we will continue indefinitely with the goal of keeping the testosterone low so the cancer does not flare.
Okay, thank you. Is the same mRNA science that was used to develop the COVID-19 vaccine being studied for a vaccine for metastatic prostate cancer?
Great question. Yeah, there's a lot of exciting research in the field of immunotherapies. We've been challenged that the majority of men, the men who don't have that MSI high signature on their genetic testing, do not benefit from those immunotherapies that have worked so well in melanoma, lung cancer, kidney cancer, and others. We saw response rates only in about 5% of men if they didn't have those genetic mutations. So that's where a lot of research is asking, can we combine immune therapies with different vaccines? So turns out there's over a dozen different types of vaccines that are out there in clinical trials. None are FDA approved yet, but we're very excited about the mRNA vaccine technology as one we can change or adapt and maybe even personalize to the patient sitting with us today to develop a patient-specific vaccine. Now, those are all exciting research trials that are ongoing. They're not FDA approved right now, but I remain optimistic for the future.
So Jane, perhaps you want to take the next couple of questions. How long does it take after the last hormone shot for side effects to subside?
Ooh, that's a good question. That might be. I'm trying to think. So libido and hot flashes and things like that. I would say 6 months. Josh, what's your thoughts on things as far as recovery once hormone stops?
Yeah, for the most part, it's really about the body adapting to that low testosterone environment now. So the hope is within 6 to 12 months that many of those side effects will go away or at least improve from when you first started. So I've had some patients, probably around 10% of men, who have persistent hot flashes despite kind of the tincture of time. And those are patients where we think about other supportive care measures, just like Jane mentioned in her talk, to try to help improve hot flashes. Fatigue, loss of muscle strength, loss of bone strength, those are things that won't improve because, again, the testosterone is low. Really, this idea that your muscles, they use testosterone as a signal to be strong. So that's where exercise plays a critical role in kind of filling that gap of stimulating your muscles to be strong, your bones to get stronger as well. Cardiovascular exercise, resistance exercise can make a huge difference. So we strongly recommend those, and the earlier the better.
Can the use of an ice cap help prevent hair loss while using chemo?
You know, I don't know a whole lot about it. I'll admit, I do know that the University of Wisconsin uses it in the chemotherapy room. The two most common chemos we use are cabazitaxel and docetaxel. Those can cause mild to moderate hair loss. I don't know if we haven't had too many men inquire about it, but I certainly would consult with our chemotherapy nurses and ask if it's indicated for someone's inquiring about it. I do know that they do use them at UW, and they are used in the chemotherapy room. So I do know it's an option.
Especially for women with breast cancer, where that's where the most studies have been performed and they were shown to be effective. As Jane said, not everyone experiences hair loss, but it is worth discussing with your chemotherapy nurse if there would be a role for that.
Having participated in clinical trials, I am troubled by the disclosure that I would not benefit from participating in the trial.
Mr. Foreman, that's a great point. I'm very glad that you brought that up. As a physician, a clinical researcher, and I'm a laboratory researcher as well, I only do research that I think is going to help my patients. If we go back in 2010, there were clinical trials that were done compared to a placebo because we didn't have anything else at that time to treat men. In this day and age, we have so many different treatment options that every man on a clinical trial should be getting some form of active therapy, whether it's a standard of care treatment or a standard of care treatment combined with something else, or a brand new therapy being given on its own for the very first time. Because of decades of challenges in clinical trials, and I'm talking going back into the 50s, 60s, and 70s, that patients weren't always well informed. And that's why that line is in that consent form, even though be sure to ask your doctor, they're doing this because they want to help you. And I just want to take a moment to thank you for your participation in clinical trials. This is how we develop new therapies for men with prostate cancer. We were part of the original clinical trials with abiraterone and enzalutamide back in 2009, 2010. And I can tell you, we wouldn't have those drugs now if it weren't for the donations of those men to be a part of those clinical trials. And obviously those drugs help those men too.
What is the difference between genomic testing and genetic testing? I had a genomic test and my doctor didn't appear to be very interested in the results.
Yeah, that's a great question. So there are, for most people, genomic and genetic are interchangeable terms, meaning they mean pretty much the same thing. The question you want to ask your doctor is, was this a genetic or genomic test performed on the cancer, or was it a test that was performed on the normal cells? There's also some other assays being developed using blood samples or liquid biopsies. There's one liquid biopsy that's specific for testing for olaparib. However, not all, even though there's a lot of liquid biopsies out there, they may not be specific or useful for determining what's the best therapy for you. So that's where it's important to discuss and ask your doctor exactly that question of which type of genetic test are you ordering and what results do you hope to get out of it? And that will help you understand what they're thinking.
All right, so there are a couple of questions here for Merrill about the laminates, if they can be printed at home, and again, the website where the laminates can be found.
Yes, absolutely. First of all, they are on our National Alliance website, naspcc.org. You can download them. You can actually have them printed back to back and laminated. They're certainly available for free for anybody. I also wanted to add, but I didn't realize I was on mute, about the clinical trial question. You're never going to get less than standard of care. So whether you're in the new arm looking at a new agent or a new type of using agent, or the other arm, you're not going to get less than standard of care. So the fact that that you might think you're not going to benefit, you're not going to be harmed by being in the clinical trial in that sense. Just wanted to add that.
Thank you.
Thank you.
Almost a year after surgery, I developed lymphedema in the left leg. Is this a common thing after a whole year?
I'm so sorry that you developed that side effect. That is an uncommon side effect. It is important to discuss that with your doctor. In uncommon situations, but it can happen, the cancer could come back and it could be blocking the lymph vessels, the lymphatics, from flowing. In other situations, it's just because the lymph nodes were removed and it was just terrible luck that something happened. So it is important to discuss that with your urologist. There are some wonderful physical therapists who are working in that space to treat lymphedema. Some are better than others, so it's important to have that discussion with your doctor as well. And if they don't know someone, I'm sure that Meryl has some great ideas in terms of other advocacy groups or other ways to help patients experiencing lymphedema.
Dr. Lang, how do you engage a patient who is a good candidate for AS, who insists on definitive therapy?
Yeah, that's active surveillance is a great question. And it does come back to those ideas of the strengths of PSA screening for cancer and also the limitations. PSA doesn't always tell us, is this an aggressive cancer? It doesn't necessarily tell us how quickly it will grow. So that's where regular biopsies and watching that PSA doubling time or PSA velocity can give some more information. One of the advances that I think is really important in this space over the last few years is the role of targeted biopsies, meaning not just a random ultrasound guided biopsy of the prostate, but actually using an MRI to guide the needle to the right place. And that, I think, gives us some comfort that those MRI scans are so good that if there's a biopsy performed of an area that's really worrisome, but it comes back and say a Gleason 6 cancer, then the likelihood of that spreading is very low. However, if this is a cancer that has, again, maybe the initial biopsy was Gleason 6, but on the MRI they found a really worrisome area and that was a Gleason 8, I think that's a clear indication to say, active surveillance is not a good option for this gentleman. So again, what you're hearing from me over and over is get more data, get more information so you can make the best decision for yourself.
This question is about insurance and clinical trials. Insurance will often not cover clinical trials. What options are then available to patients?
I'll start with that, and then Jane, please jump in if there's other things that you'd like to discuss. Briefly, clinical or insurance should never cover the cost of an experimental therapy, meaning this is a treatment we don't know if it works or not, and insurance companies should not be billed for that. That should be covered by the clinical trial. Sometimes there's other blood tests or research scans being done. Also, again, because those are not standard of care treatments, they should be paid for by the clinical trial. They should not go to your insurance. They should not go to you. Things that are considered standard of care, meaning no matter what treatment you're getting, you would have these tests done anyway, such as getting your PSA checked, coming in to see your doctor, getting those regular CAT scans or bone scans. Things that, again, no matter what treatment you're on, you would be having done. Those are things that would be billed to insurance. But again, this is an important topic and something that Jane works with every week with our patients on clinical trials. Jane, did you have any other comments?
Yeah, the insurance company is only for, personally, what I've experienced is that the insurance company is only going to see bills related to standard of care tests. They're not going to be seeing anything associated specifically with the clinical trial, meaning the study drug itself or any study specific labs or study specific scans that are considered experimental, or so those should be covered by the trial. But anything standard of care, the clinical, anything standard of care, the insurance company should cover, and those are the costs that they see. So I hope that answers your question.
After surgery, radiation, and hormone therapy, my PSA is undetectable. Does this mean I am cured or in remission?
That's a great question. So in prostate cancer, I never used the term remission. Remission was a term that was developed actually when we were treating leukemias with very aggressive chemotherapies. So I don't use the term remission, but in that situation, our hope is cure. Now, that's where you do want to continue to have regular PSA checks and follow with your urologist. They'll vary the timing of or the interval of getting those PSA checks. Usually it's every 3 or 6 months. But we're really hoping for cure, and I'm hoping for cure for you as well.
When can genetic testing be conducted? Would there be issues getting insurance to pay for it?
It's a great question. Genetic testing is FDA approved and is recommended by NCCN and by the FDA. Insurance should cover the cost of it. You may need to have that discussion with them. There are some research studies also going on at different institutions, so also be sure to ask where genetic testing can be done for free. So those are important questions to ask, but it should be covered. I can tell you we have had challenges though, and not just for getting insurance to cover some of these standard of care genetic tests, but also standard of care treatments. So it is important that if you have the unfortunate diagnosis of recurrent or metastatic cancer, find out what your insurance company covers as soon as you can. And if you need to upgrade to a different insurance carrier, it's worth doing that, especially in the long run for a disease that, as I said, we're hoping to treat for years and years and years. So make sure you have good coverage so you can get access to all of these life-improving and life-saving treatments.
So Dr. Lang, perhaps you can take this next one. Let's see. I have oligometastatic treated with SRS, with Erlida and Zytiga plus Lupron. Is hormone therapy only with radiation and I'm not sure about the rest.
Or continuously. Yeah, so the hormone therapy with the Lupron is something that we will continue almost indefinitely. The research studies are still ongoing to ask if treating oligometastatic prostate cancer with radiation therapy with SRS is curative or not. Some of the early studies have shown that it can delay the time to PSA progression, but we don't know if it helps men live longer or what that chance of cure is. Larger clinical trials are going on right now, but we don't have the answer to that question yet. So be sure to discuss with your oncologist. Generally speaking, most of us are going to recommend continuing the hormone therapy indefinitely.
Great, thank you. Why does Medicare cover IV treatments but not the oral treatments?
Yeah, this is going to take us back a few decades here in terms of just Medicare and government policy. And I think when you look at Medicare A and B, and then when you start looking at Part D drug coverage. So Medicare Part D was developed to cover oral prescription drugs, while IV therapies fell under those other categories of Medicare. Now, I don't claim to be an expert. We have amazing pharmacists who help us navigate this world we live in and the challenges between Medicare, supplements, and other insurance companies. So it's so confusing. So be sure that if you have questions, your doctor may not have those answers, but that's why we try to work as a team. Our research nurses, our clinical nurses, our pharmacists, our social workers, they can be incredibly helpful as we navigate the healthcare spectrum. Meryl, I don't know if you have any other comments that you would like to add on that topic. Oh, I think you're on mute, Meryl.
Sorry. I think you did a great job covering that. I don't have anything to add.
Should PSA be used as a screening tool in Black patients with strong family history of cancer?
That's a really important question, especially in the setting of a family history of cancer. I strongly recommend genetic testing. So that should be looking for those BRCA1, 2, or other genes and asking, is there something that could have been inherited? Because that also changes the screening guidelines too, not certainly for you, but also for your loved ones. So that's where screening, especially for men who have a family history. So for example, if one of my patients was diagnosed with prostate cancer at the age of 50, his sons should have their PSA checked at least 10 years before, starting at the age of 40. We should also do germline genetic testing, meaning looking at the normal cells. And if we see a BRCA1 or 2 mutation, his daughters, they need to be screened as well and consider for mammograms and other tests or risk factors for breast cancer. I think especially, and while there's been changes to this PSA screening guidelines, and I've got a whole lecture I can give on that as I try to educate our internal medicine colleagues, but it's just so important that if there's a family history, that you have screening done early.
Great, thank you. I've just been diagnosed with a 9 on the Gleason scale. I might have been told that it is, and I have been told that it is aggressive. What does this mean to me?
That's a great question. So what the Gleason score was developed, and this is going back into the 1950s, essentially looks to say, does this look like a normal prostate cell or does it look like something completely different, completely unusual? Now, what Gleason score is most effective at is saying, is this a cancer that could have already spread outside of the prostate by the time someone has surgery? Importantly, Gleason score does not say if this is a cancer that would be sensitive to the different treatments that we've discussed today. So unfortunately, if this cancer does come back, meaning the PSA is rising after surgery or radiation, and scans may show metastatic cancer, the Gleason score doesn't really help me at all. This is now when I need to be thinking about genetic testing and trying to understand what type of cancer this is and go through those different therapies that we discussed earlier.
Okay, thank you. Is the use of combining cabazitaxel and carboplatin as a chemotherapy treatment common, or is the use of these separately better?
That's a great question. And this is where we come back to what are the features of the cancer. So there was one clinical trial that asked for men with very aggressive prostate cancer, meaning large lymph nodes or spots of cancer in the liver or lungs, and a few other features, that the combination of carboplatin plus cabazitaxel was better than cabazitaxel alone. However, as you can imagine, there were also more side effects. Again, many of those are manageable, but there are still more difficulties such as prolonged fatigue. So that's where if there are some of those features of very aggressive prostate cancer or other genetic tests showing that neuroendocrine prostate cancer that I mentioned, that may be the recommendation from your doctor. But if we don't see those signs and this looks like the original adenocarcinoma, but one that's causing symptoms, that's where cabazitaxel can be very effective.
Okay, thank you. We had a question yesterday regarding treatment and the results and how it could be related to the COVID vaccine. So it says, I had a PSA of 2.58 before RP surgery. I did 6 months ADT. At 10 months, I did LU-177 treatment in order to avoid ADT and radiation therapy. For 3 months, my PSA was undetectable. In the last 3 months, PSA at 0.023. And so the question is, well, what should I do? Could this be related to the COVID vaccine I did?
I'm very glad that that question was asked. There is no evidence that COVID vaccines have any impact on prostate cancer recurrence or response or sensitivity to these therapies. So the COVID vaccine would not have an impact. I think what you described was a very different type of a treatment course. And I think it's something that the concern is that this is a cancer that survived despite the therapies that you received. So we do want to look at doing updated imaging scans and potentially a biopsy to, again, figure out what kind of cancer is it that's being fought. The concern is that if a cancer is spread outside of the prostate, or even if there's cancer in the prostate, but the PSA is low, meaning less than 4, this may be a cancer that's not as sensitive or dependent on hormones, in which case the use of only hormone therapies may not be enough. And we may need to think about other types of ways to attack this cancer. And again, highlights the importance of genetic testing.
Okay, thank you. What should the regular follow-up with doctor or testing be? What should it look like after a complete prostatectomy where there appears to be no signs of cancer in the year or years following?
Well, and that's absolutely what we're hoping for, is that this was a curative intervention. Generally speaking, a urologist may recommend PSA checks every 3 to 6 months, though that can vary depending on what they saw in the prostate surgery. And if it's a lower risk prostate cancer, such as a Gleason 6 cancer, may not need as frequent monitoring for PSA checks. But higher risk Gleason scores, again, things that can associate with cancers that may spread outside of the prostate, that's where we may recommend more frequent monitoring.
Can you speak more to your comment? Does the cancer look like the original cancer? Is it possible for a stage 4 cancer to be downgraded to a lower stage?
It's a great question. Unfortunately, when cancer has spread outside of the prostate to other tissues in the body, lymph nodes, bone, or other places, that's considered a stage 4 or metastatic prostate cancer. Unfortunately, that is not a cancer that we were able to cure. Though, as I mentioned, one that we can hopefully treat for many, many years.
Since men are living longer, when do you begin discussion about bone health, for example, osteoporosis?
That's a great question. So, especially when men start hormone therapies, we do recommend that they have a bone density scan performed. Now, if we do see any signs of osteopenia, we'll recommend more frequent monitoring, because there's roughly about a 2% incidence of bone loss for every year on hormone therapy, which means that if someone has osteopenia before they start hormone therapies, they could develop full osteoporosis within 1 to 4 years. And again, this is a disease we hope that we will be treating for many, many years. And if we see signs of osteoporosis, treating bone health with agents such as denosumab or zoledronic acid can help decrease or improve osteoporosis, but also decrease the risk of a fracture.
Okay, thank you. Should you do genetic testing only after metastasis has set in?
It's a great question. If there's a strong family history, we do consider testing those normal cells in the body. Again, asking, is this something that could be inherited? If the cancer comes back, we often, again, as I mentioned, start hormone therapies, but you should have that discussion with your doctor of what's the right time to do that biopsy. We know that cancers, when they become resistant to the treatments we're giving, something changed about them. And a biopsy and genetic testing is usually the first place we start to try to figure out why that happened. So while sometimes we recommend getting that genetic testing before starting treatment, I definitely recommend a biopsy if the cancer is becoming resistant to hormone therapies or to drugs like abiraterone, enzalutamide, apalutamide, or darolutamide.
Okay, thank you. So here's a specific genetic test question about ONCOFOCUS in the UK. They found AKT1 genomic alteration. Any specific suggestion?
Yeah, that's a great question. And especially if you're in the UK, you have some amazing oncologists in different institutions, including Dr. Johan de Bono, international leaders in the field. AKT mutations, that's a gene that can be involved in essentially activating a cascade of different proteins that can stimulate cancers to grow faster. There are drugs in clinical trials being developed to try to block that protein or block that gene if it's hyperactive. They have not been approved by any of the regulatory agencies like the FDA or NICE for those cancers, so those trials are still ongoing now.
And what is the minimum genetic testing?
So if we're talking about looking at the normal cells, then we want to speak with the genetic counselor. And again, that's usually looking at somewhere around 40 to 80 genes. There are a number of tests out there that perform that. If we're looking at the cancer genetic testing, we want to look for tests that generally look at anywhere from 400 to 800 different genes. Usually that's from a tissue biopsy. There's a number of ones out there. Again, they haven't been compared head to head. For the most part, we think they're mostly about the same. There are some other kinds of genetic tests that are performed on just prostate tissue when men are trying to decide if they should have surgery or not. I should mention those are not the kinds of genetic tests I'm describing for advanced prostate cancer. There is also some other work going around with liquid biopsies, asking, can we do a blood draw and look for genetic mutations that could be found in cancer there? There's a few different ones out there, but only a couple are approved by the FDA for the use with olaparib or rucaparib. And that's, again, important to check with your doctor. Those blood tests are not as specific, and sometimes they can make more mistakes than getting a tissue biopsy.
For a cancer that is not indicated by PSA, how does one detect its presence?
Scans are the most important. CAT scans and bone scans, we're not clear if PSMA PET scans will work very well for men whose cancers don't make PSA. So PSA and PSMA, they're both genes that are regulated by hormones. So if hormones aren't working or aren't needed for that cancer, again, if the PSA is not elevated, those scans probably won't be effective.
Great, thank you. Can you please elaborate on how you define symptoms for metastatic CRPC to qualify your patients as symptomatic?
Every one of my patients is different. I have some patients where they may have only one spot of cancer in the bone, and they say, you know what, this is really impacting my quality of life. I'm not up and active and doing the things I want to do. To me, that's symptomatic, and we need to look for ways to help those symptoms. I have other patients where they have spots in different areas and different bones, but really no symptoms at all. In which case, again, it comes back to, is this something impacting your quality of life?
Here's another question about genetic testing. I had a radical prostatectomy undergoing ADT for 3.5 years, shots at 3-month intervals, PSA less than 0.1 since started. Would I be a candidate for genetic testing, and would my doctor likely agree?
That's a great question. Depending on what those PSA kinetics, and as Meryl described from the laminates of, what is PSA velocity? What is PSA density? And is this something that's changing quickly that's worrisome for a cancer that might cause problems, and we need to treat that? Genetic testing initially for men who have what we call, again, castrate-sensitive prostate cancer, meaning a cancer we have not treated with hormone therapies yet. Genetic testing is not going to initially change my recommendation, especially when we're thinking about abiraterone or chemotherapy. But it is something to have that discussion and start it early, so that way you can understand what your doctor knows and what they think about genetic testing.
Does NCCN recommend platinum-based chemotherapy in whole or in part for men with BRCA mutations who have failed a PARP1?
Great question. So what we know about the BRCA genes and others in that family is that they're important for cells, basically, if the DNA gets damaged, for fixing that damage. And some cancers, if their cancer is mutated, they're even more effective at that. So that's where drugs like olaparib and rucaparib help to block that and prevent a cancer cell from essentially repairing its DNA. Now, platinum drugs like carboplatin and cisplatin, they have a similar effect in terms of, again, preventing the DNA from repairing itself. So that is an option for men whose cancer has become resistant to those kinds of PARP inhibitors.
Thank you. So this question is for Meryl and Mark. I'm wondering if we could go back a few slides. So the question is there a laminate available for mCRPC?
Not yet. That's next on our list. I should have mentioned we have several process. mCRPC, there'll be one on imaging, one on testing, one on immuno-oncology, one on bone health, and one on pain management and advanced prostate cancer. The next one that will be published is actually the mCRPC. We don't have that yet.
Thank you, Meryl. So I see a treatment question here in the Q&A box for Dr. Lang about when to trigger actions according to the PSA slow growing.
That's a great, those are great questions. I think especially when we talk about this term, the PSA doubling time. And there were some old studies that were done in the 90s and early 2000s at Johns Hopkins. And what they found is that for men who had a PSA doubling time that was doubling faster than 7 months, that meant that those men in that category were more likely to have cancer show up on the scans within 2 years. So that suggests that may be a risk of a group of men that are higher risk. Now, the challenge is if a PSA is very low and if it goes from 0.3 to 0.03 to 0.06, that absolute number is still really, really low. When we think about the chance of actually finding something on a scans, for example, the PSMA PET scans, we're very excited about those scans, but some of the recent studies that have been performed with that found that For men with a PSA between 0 to 0.2, we only found cancer in 42% of the time. From a PSA of 0.2 to 1, we found spots concerning for cancer 58% of the time. If the PSA was greater than 2, we were able to see spots of cancer in 95% of patients in that one particular study. So really what that highlights is that our scans are better than they ever have been, but they're not perfect. And if the PSA is slowly rising and no symptoms from the disease, we don't necessarily need to rush into a therapy. We may need to treat that cancer with hormone therapies, but as there's side effects from the hormone therapies, we'd like to push that off as long as we can. It's also a great chance to exercise more and get more fit. I know the more fit my patients are, the fewer side effects they have from any of the therapies we give to treat their cancer.
What is the clinical distinction between HSPC and metastatic HSPC?
Great question. And you'll hear this HSPC and CSPC term. They're essentially the same: hormone-sensitive prostate cancer or castrate-sensitive prostate cancer. The distinction is that M, and that M stands for metastatic. So if someone has a rising PSA and we do scans but don't see any signs of cancer on the scans, that's considered a non-metastatic CSPC or HSPC cancer. If we do see a spot of cancer on the scans, lymph node, bone, or other areas, that's what we would consider metastatic.
Great explanation. Thank you. If a patient PSA level is very high and bone scan shows METs, is a biopsy of the prostate still needed?
That's a great question. I do recommend having that discussion with your doctor. For example, if the bone scan shows very tiny areas and our radiologist say, you know what, I don't think I can do that. It's not, the chance of being successful is very low. That's when we do recommend a biopsy of the prostate. That's the best way to make sure we get enough tissue that we can make sure this is actually prostate cancer and not something else, because there are other things that can show up in bone, but also enough tissue to do genetic testing. But especially if there's an area where your doctor thinks, you know what, this is probably the safest way to do this without going through the process of a transrectal biopsy, then that's an important discussion to have.
I see a few thank yous to our presenters in our Q&A, so I just want to extend those comments. The next question, what are the pros and cons of different NGS tests like Foundation One, Tempus Labs, etc.? I read Tempus enrolled a patient in a trial in 9 days after sequencing the tumor. Is that fast?
Yeah, that's a great question. For the most part, many of these tests are very similar. And again, they've never been really compared head to head for men with prostate cancer. 9 days is very fast. Generally speaking, if it's 9 days, they were only looking for one specific gene. When we look at hundreds of genes, you can imagine that that takes longer to process and analyze that sample to get those results. So different trials and different tests have different requirements. So you want to try to match those up. But oftentimes it's what's accessible and what insurance covers the cost for those genetic tests as well, because they can be expensive.
How does one know when to start hormone treatment for micrometastatic recurrent prostate cancer when PSA is still rising, but slowly, with a doubling time of 18 months?
It's a great question. If there's no signs of cancer on scans and the PSA doubling time is 18 months, the chance of something showing up on the scans could be years away. And that's when we want to weigh the risks and the benefits of the hormone therapies. As we mentioned, there are side effects of hormone therapies. We, generally speaking, do not recommend hormone therapies if someone has no signs of cancer on scans, a prolonged PSA doubling time, and they're otherwise doing well. Again, quality of life must always be a part of our considerations when we recommend any treatment for any stage of prostate cancer.
I had metastatic prostate cancer diagnosed since June 2017, started ADT at the time and continuing now. Is there a benefit to taking a vacation from ADT, or is the risk too high?
That's a great question. There was one clinical trial that was done asking, is continuous hormone therapy better than what we call intermittent hormone therapy? Meaning staying on ADT for a year and getting a maximal response so the PSA becomes undetectable, and then stopping and then monitoring the PSA every 3 months with plans to resume if the PSA starts to rise, but certainly if it reaches a threshold of 5 nanograms per milliliter. Now, that clinical trial found that for men who are on the continuous arm, they actually had a better survival. They lived longer than those who were on the intermittent approach. However, those men on the intermittent approach also found that they reported a better quality of life. So I think this really comes back to a discussion with your doctor of, if you're not having any side effects from the hormone therapies and it's continuing to work, we generally recommend continuing that. However, if you're having significant toxicities, for example, some of my patients with diabetes that have struggled to control their blood sugars, if their PSA is undetectable and they're doing great, that may be a good reason to take a break from the hormone therapies.
So another question about if PSA rising after a prostatectomy, but not at level that is considered recurrent, 0.08. Are rescans necessary, or can it be assumed that as long as under the recommended levels, it has not metastasized?
We are very worried. Once the prostate has been removed, that's really the only place in the body that can make PSA. So if we detect any PSA, that's very worrisome. Now, some of those ultra-sensitive PSA tests that have been developed might show PSAs, again, incredibly low. It's a good time to have a discussion with a radiation doctor, as there's some recent studies suggesting that radiation earlier, if the PSA is rising, can be more effective. But again, there's side effects to radiation. So it's an important discussion. It's not a slam dunk either way. So monitor that PSA, though. That is important to continue to check up on, because there are other therapies that we may recommend if it continues to rise, and definitely if it spreads.
Thank you. Here's a question about someone on chemotherapy and the vaccine. Is there any information available regarding the duration of protection offered by the COVID-19 vaccine? There have been several recent articles in media suggesting that chemotherapy patients might not have sufficient protection to go maskless and or cease following social distancing guidelines.
Great question. This is an area where we're still learning a lot. What I can tell you is that we know that the vaccine is incredibly effective at decreasing the risk of either contracting COVID or having a severe infection if COVID is contracted. The concern, as I mentioned before, is that chemotherapy can knock the immune system down. Generally speaking, it's not the immune cells that are affected or that are responsible for responding to a COVID infection. Those are the T cells. I worry about the neutrophils from chemotherapies. Again, two different types of immune cells. At the same time, we'll always be a little bit worried that there may be a risk with chemotherapy. Our hope is that the vaccination rates will continue to increase in the United States and that the incidence of COVID will drop, and especially for our younger population. So there is a concern, certainly in small groups where everyone in that circle of colleagues or friends is vaccinated and with no signs of other illness. I think that's a good thing, and creates opportunities to take the mask off. At the same time, even before COVID, I was always worried if one of my patients was on chemotherapy and they were around someone who's actively ill, cold or pneumonias. That's something that any patient on any chemotherapy should always be watchful and careful for, regardless of COVID.
The next one says, on Leuprolide since December, now spread to bones and liver. What type of treatment for this condition? Gleason score 9, current PSA reading 6.
I think this is an important time to get a biopsy. If with a low PSA, but a cancer that's spread to different parts of the body, including the liver, we want to know why that's happened. The liver is usually a relatively safe place to do a biopsy from for genetic testing, and also to ask, is there any signs that this could be a neuroendocrine prostate cancer? In which case then chemotherapy and potentially platinum doublet chemotherapies would be the recommendation.
I'm looking through the questions. I see more about genetic testing. What are the best options for genetic analysis for patients with widespread bone mets but not detected soft tissue mets? Are such tests approved for non-research use? How effective are these tests for guiding treatment options?
Great question. So if cancer is in the bones, that's an important area to do a biopsy from for genetic testing. Again, at an institution that does a lot of these kinds of biopsies, the success rate can be 80 to 90%. A decade ago, the success rate was only 50%. And again, that's because of technology improvements for our providers, our radiologists who do those biopsies. So it is important to have that discussion. And if the center that you're at is not able to perform those kinds of biopsies with a high success rate, you want to get to a place that does. The tissue needs to be collected and processed in a way focused solely on genetic testing. So that's, again, something else that you want to make sure that the institution understands just how to do that right. But otherwise, we should be able to do genetic testing from that sample and help guide us of, is this something where we would consider olaparib or rucaparib for this patient, or even pembrolizumab if we see that MSI high signature, or maybe a clinical trial for a specific or less common genetic mutation like the AKT mutation that was mentioned earlier.
If I had a prostatectomy over 10 years ago, is somatic testing worthwhile? Would you consider circulating tumor DNA testing?
It's a great question. We do not recommend blood-based or liquid biopsy tests, such as circulating tumor DNA tests, for men who, or any patient who does not have any signs of recurrent cancer. The reason being is that the risk of making what we call a false positive, meaning you see a genetic mutation and assume that it's the cancer. Some very important research has come out of the University of Washington with Dr. Colin Pritchard, one of my friends and colleagues, that found that there can be some small mutations in blood cells that don't mean anything at all. And that's that risk of making a mistake, that someone's told they have cancer when they really don't. So if there's no signs of PSA recurrence and you're that far out from your prostate surgery, our hope is that you've been cured.
This next question is about dosing of abiraterone. And if the NCCN guidelines have been revised, if you can take a lower dosage with food, lower dosage of prednisone. So I'm not sure if you want to handle this, or we can refer them to the clinical practice guidelines for that.
I can tell you this is something that we discuss every single year, and that there was one smaller clinical trial that suggested they may work just as well if you take it with food. Some other trials didn't have that same evidence. So generally speaking, if cost is an issue, that's something that may be an important discussion about the number of pills to take. Again, the concern is, does it suppress the testosterone almost to zero the way it should if you're not taking as many pills? An important question for your doctor.
Mm-hmm. What is your view on treating the prostate gland for men diagnosed with de novo metastatic prostate cancer?
The most clearest indication is if someone's having symptoms from that local cancer, again, the place that it started. Most commonly difficulty with urination or pelvic pain. We don't have clinical trial evidence that treating the primary tumor improves survival, meaning does it help men live longer, especially because there are side effects from radiation. Those larger clinical trials are going on right now, and I'm hopeful we'll have data that I can give you a much better answer about. But the clearest indication is if you're having symptoms from that prostate.
Okay, and I see two more questions, and then I think we are at time. Is there any value to doing genomic testing on an 8-year prostate tissue sample, even if salvage radiation took place 3 years post-surgery? Would radiation have changed the nature of the remaining cancer?
It's a great question. There is a possibility that it could have changed the cancer. So if possible, if this is a cancer that comes back after radiation, do those scans. And if there's something that's amenable to getting a biopsy safely performed, we would recommend that for genetic testing. However, if there's a strong family history of prostate cancer, breast cancer, pancreas cancer, and others, like I mentioned, cancers that can be associated with those BRCA genes, you may want to have a test done on the normal cells. Again, getting genetic counseling and looking at those normal cells to see if there's something that could have been inherited.
And this next question, I think, also relates in some way to what you're saying about if something has been inherited. And so here we have someone diagnosed with stage 4 metastatic prostate cancer in October 2020 with a PSA of 19. And then I see some treatment details, but what's mentioned is that his wife died at 44 with breast cancer. Both daughters have the BRCA genes and had preventative mastectomies. Am I a candidate for testing? Why or why not?
Great question. If this was something where your wife and your daughters had those genes, That's not something that you would inherit as the spouse. However, given your history of prostate cancer, that may be something important, especially if this is a cancer that comes back and we want to evaluate for olaparib or rucaparib. It may also be important if you have siblings who may also be at risk for cancer as well.
I see. What are the consequences of taking less than the recommended dose of a certain medication?
It's a great question. It's something I talk with all my patients about. Just really briefly, all of our clinical trials, and this goes back to the 60s and 70s, we said we think more of a higher dose will be better in terms of having an anti-cancer effect. And we found that that was more associated with chemotherapy, but with these targeted therapies, it doesn't seem to hold as much water. As you can imagine, every person is different in terms of when we take a pill, how quickly does our body metabolize it or break it down and get it out of the system? So for some patients, that highest dose is too high, meaning their body doesn't break it down or metabolize it as quickly, in which case giving a lower dose may be just as effective, but hopefully fewer side effects. Again, quality of life is always one of our priorities, while we're also looking at quantity of time. However, if we see that the cancer is becoming resistant, whether that's new symptoms or a rising PSA, we may recommend going back up to that higher dose to see, can we get a response back? That's really pretty uncommon though. Usually when cancer becomes resistant to one of these therapies, it's because of a genetic mutation, and changing the doses won't have much of an effect. And you want to be asking your doctor, is this the right time to do some other kind of biomarker or genetic testing?
Great, thank you so much. Thank you to everyone who submitted questions. We are out of time for today. Thank you everyone for attending. Once again, thank you to our presenters. The NCCN Foundation would like to also thank the corporate supporter of this webinar.